I was going to make a joke about vision, but I think you won't see the point. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at two very important, yet it confuses so many people, diabetic and hypertensive retinopathy. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Drop a like, drop a comment to Zambia and beyond. Let's go. No warm-up question today because this isn't really a topic per se, but rather a subtopic in another topic, kind of like Inception, a topic in a topic. I know that did not land very well. Anyways, we'll begin with the normal fundus. So this is what the normal fundus actually looks like on a fundoscope, which is a machine that is used to look at the fundus. So there are some key parts that you should be able to identify. So you should be able to identify the optic disc over there, or the optic nerve head. This is where all the blood vessels are going to be converging. As you can see, these red things are referred to as blood vessels for those that don't know. So this is known as the optic disc. Then lateral to this, or at the temporal region to this, you have this entire bit here, which is known as the macula. Remember that the macula is the area where you have your highest number of cones on the retina. And then at the center of the macula there, you have the fovea centralis, which is pretty much the point where there is the maximum visual acuity. So remember that the optic nerve is going to be found by tracing pretty much any blood vessel to the point where they merge or where they are branching off from. That's where you are able to find the optic disc. And then the macula lutea the macula is just right lateral to the optic disc. And then it has a small part here at the center, which is known as the fovea centralis. It's a darker pigment than the rest of the macula. So I hope you have a picture of this and you have a very good understanding. So we'll start with diabetic retinopathy. Remember that this is a complication of diabetes, a microangiopathy, which is going to be affecting these small blood vessels, and it's going to be as a result of hyperglycemia that is associated with diabetes. 30% of the patients actually develop this, and it is actually one of the major causes of blindness, particularly among working age adults. Now, the degree of the retinopathy is going to be correlated with three main things. The first thing is going to be the duration of the diabetes. The second thing is going to be the blood glucose, which is going to be poorly controlled, obviously. The third thing is going to be the blood pressure of the individual. Pregnancy also does affect the retinopathy, so it does impair blood glucose control. It can actually worsen retinopathy. And you have other risk factors like hypertension, hyperlipidemias, and smoking. Remember that diabetes also increases the risk of cataracts and glaucoma. So the three things that are going to be causing blindness in an individual: diabetic macular edema, I'll talk about it, cataracts, and glaucoma. Not really diabetic macular edema, but diabetic maculopathy. Anyways, but it is macular edema in essence. So diabetic macular edema, cataracts, and glaucoma. Those are the three things that are going to be causing blindness. So patients that actually have diabetic retinopathy may have blurred vision. They may have floaters. I'll show you a very nice picture of what these actually kind of look like. You may have vision loss. So usually this is absent until the advanced stages of the disease. So what are some of the terms that I'm going to be mentioning throughout in this lecture? You may have microaneurysms, you may have dot and blot hemorrhages, you may have hard exudates, you may have cotton wool spots, you may have venous beading, which is the dilatation and loops, you may have intraretinal microvascular abnormalities, or IRMA. So the microaneurysms are just pretty much these small red dots, and these are just the earliest signs. I will show you what they look like. Then the dot and blot hemorrhages also look very similar to microaneurysms, and these are just as a result of the aneurysms rupturing. The hard exudates are just pretty much lipid and protein leaking out from the vessels. Cotton wool spots are pretty much the retinal nerve fiber ischemia. Then your venous beading and your loops is pretty much retinal ischemia. Then your intraretinal microvascular abnormalities, or IRMA, is just pretty much remodeled capillary beds. You may not be able to actually identify these, especially at undergraduate level, so don't worry much about this. So here are what they look like. Before I actually go into a lot of details, I just want to give you some perspective. So over there, you have a cotton wool spot. Okay, so this is what a cotton wool spot looks like over here. Over these yellowish particles here, these are hard exudates. Then this reddish like dots and spots, hemorrhages, they're very similar to microaneurysms. And then you also have microaneurysms, which are kind of like these reddish spots. So these are microaneurysms, cotton wool spots, hard exudates, and hemorrhages. So previously, the grading system was divided as follows, and most medical schools will teach you this, but there is a newer grading system that we are now currently using. So previously, we used to divide it into 4 main stages, from early signs to late signs. We had the background diabetic retinopathy. We have the pre-proliferative diabetic retinopathy. These two now have been merged together and put in a class which is known as non-proliferative diabetic retinopathy. So the previous classification divided these 2 stages, but the newer classification combines these 2 stages, and then you pretty much talk about the non-proliferative diabetic retinopathy. Then you have the proliferative diabetic retinopathy and the advanced diabetic retinopathy. So they're just two groups now in the newer classification. I will point to it later on. So these are the 4 main stages, and I'll describe them in detail before I actually give you the newer classification, because I find it easier to actually learn using this classification. Then we go to the newer classification. It'll be much easier to understand rather than me teaching you the newer classification first. So we'll begin with background diabetic retinopathy. So here you have predominantly your microaneurysms, and you have your dot and blot hemorrhages. So what are these microaneurysms? These are just pretty much the localized outpouchings of the capillary that leak plasma constituents into the retina. They are very clinically indistinguishable from the small dot and blot hemorrhages. Like I said earlier on, it's very hard to actually distinguish between the microaneurysms and the dot and blot hemorrhages because they appear as red dots. Then the dot and blot hemorrhages are going to be arising from bleeding capillaries in the middle layers of the retina. They may look like microaneurysms if they're small enough. So actually, it's not even particularly important to be able to distinguish between these two even on your exams or even just in any patient, because whether the patient has small hemorrhages or microaneurysms, they are still going to be part of pre-proliferative retinopathy or non-proliferative diabetic retinopathy. So this is what the microaneurysms look like. So you can see these swellings over there. Those are the microaneurysms. The dot and blot hemorrhages, you can see that there are dots over there and blots all over the retina. So I hope this is making sense. Then we move to the next stage, which is the pre-proliferative diabetic retinopathy. So here there's going to be retinal ischemia, and there's going to be progression from background diabetic retinopathy to a pre-proliferative stage. So you're going to be seeing some other things that are coming up. So your cotton wool spots, which are just going to be these small, fluffy, white superficial lesions, they're just simply accumulation of nerve cells from the ischemic damage. You may have venous changes, you may have intraretinal microvascular abnormalities, which is remodeled capillary beds. You're not going to be asked to actually identify this at undergraduate level. Anyone who would be asking you to do that would be quite unfair towards you. So this is what the cotton wool spots look like over there. So these are the cotton wool spots. So the cotton wool spots are just pretty much soft exudates. Then you have the proliferative diabetic retinopathy here, where there is insufficient retinal perfusion. There's not enough oxygen getting there. Remember, when there's not enough oxygen that's getting there, the endothelium is going to be producing what is known as a vascular endothelial-derived growth factor. And this is going to result in the development of these new blood vessels, which is a process that we call neovascularization. So once you form these new blood vessels, they can either form at the optic disc, you have these new vessels at the disc, or they can form in areas of the retina, so new vessels elsewhere on the retina. So this is what they look like. As you can see, there are like some new vessels that are being formed here at the optic disc. So these are new vessels at the disc, and here you have new vessels that are being formed elsewhere. So this is the neovascularization that we talk about. Then in the advanced diabetic retinopathy, here you're going to be having recurrent vitreous hemorrhage, from bleeding areas of the neovascularization, because new blood vessels, as they are forming, they're not as tight as the quote unquote tight as the older blood vessels, so they may actually leak out certain things. Then you may sometimes have tractional retinal detachment, which is areas of neovascularization. As they grow into the vitreous cavity, they may actually form fibrous bands and actually suspend the retina. So the retina may actually begin to tent. It appears like a tent. You may have rubeosis as the neovascularization occurs at the iris, and the draining angle results in increased intraocular pressure, and of course this may cause progressive glaucoma. Then you may have diabetic maculopathy, which is an end stage, if you were to think of it like that. So you have the presence of these exudates and even macular edema at the macula. You are unlikely actually to even identify this on the images that you may get, because it's very hard to visualize using direct ophthalmoscopy. Then the hard exudates, remember that these are going to be waxy yellow lesions with relatively distinct margins, arranged in clumps or sometimes rings, often surrounding leaking microaneurysms. The reason why we call them hard exudates is we want to distinguish them from soft exudates, which is an older term to actually refer to cotton wool spots. So this is what the hard exudates actually are. You see these yellowish rings that are surrounding this hemorrhage there in the center. So these are the hard exudates. So this is the newer classification. So what I was giving you is a previous classification. This is the newer classification. It's just divided in two groups: non-proliferative retinopathy, proliferative retinopathy. In either one of the cases, you may have diabetic macular edema that can happen in either one of them. And remember that diabetic macular edema is actually the most common cause of vision loss due to diabetic retinopathy. So in the non-proliferative retinopathy, this was the one that was previously divided into two main groups. That's your background retinopathy, where you have your microaneurysms and your hard exudates only, and also your pre-proliferative, where you have everything else, the other things that I mentioned earlier on. So now here you have this developing first. It may cause increase in capillary permeability, microaneurysms, hemorrhages, exudates, macular ischemia, and macular edema. So you may have thickening of the retina, which is caused by the fluid leakage from the capillaries. It's going to be divided into mild, intermediate, and severe. So with the mild, you just have microaneurysms only. We call that as a mild. Then if you have severe, in all the four quadrants of the fundus, you have hemorrhage or aneurysms, or in two or more quadrants, you have venous bedding, or in one or more quadrants, you have the intraretinal microvascular abnormalities, that's your capillary bed remodeling. Then you will refer to that as severe if you have any one of these three. Then anything else that is in between is considered as intermediate. Then the proliferative retinopathy is pretty much going to be new blood vessels that are forming. It's actually much more severe. It may lead to vitreous hemorrhage. So you may see floaters, you may see flashes, you may have this sudden painless loss of vision. You may sometimes even have traction retinal detachment, which is a tinted retina. So here you have these abnormal new blood vessels that are forming. This can occur in the inner or the vitreous surface of the retina, and this may actually even extend into the vitreous cavity. So this is what is going to be causing the vitreous hemorrhage. So the neovascularization is going to be accompanied with a pre-retinal fibrosis or pre-retinal fibrous tissue rather, which is going to be along with the vitreous and actually can contract and can result in traction retinal detachment. And this neovascularization also may occur in the anterior segment of the eye. On the iris, the neovascular membrane actually can grow into the anterior chamber at the angle of the eye and at the peripheral margin of the iris, and this can actually lead to neovascular glaucoma. Remember that vision loss with proliferative retinopathy may actually be much more severe. So what are some of the clinical features that we get? So remember two main groups: non-proliferative retinopathy, proliferative retinopathy. So in the non-proliferative retinopathy, you get symptoms that are caused by macular edema or macular ischemia, but patients may not have the vision loss even with the advanced retinopathy. So the first signs that you see are your capillary microaneurysms, your dot and blotch retinal hemorrhages, your hard exudates, and your cotton wool spots, which are essentially your soft exudates. Then The hard exudates, like I already described, are these discrete yellow particles within the retina. When they are present, this is going to be suggesting that there is some chronic edema. Then your cotton wool spots are these areas of microinfarction of the retinal nerve layers that actually lead to retinal opacification. So you get these fuzzy-edged white obscuring the underlying vessels. Then in the later stages, you may get macular edema, which is seen on the slit lamp biomicroscope as elevation and blurring of the retinal layers. You may also get venous dilatation and intraretinal microvascular abnormalities. That's in the later stages. So again, here's an overview: your microaneurysms, your cotton wool spots, your hard exudates, your hemorrhage over there. So try and identify the pathologies here. Comment in the section below, and I will respond to your comments. So what are the clinical features of proliferative retinopathy? So here you may have symptoms that may include blurred vision. You may have floaters, which are these black spots in the visual field. I'll show you a nice picture very shortly. It's quite funny. So you may have flashing lights, which is, I don't want to pronounce this, in the visual field. You may also have sudden, severe, painless vision loss, and then these are actually symptoms that are typically caused by vitreous hemorrhage, or they may be caused by traction retinal detachment. Remember that in proliferative retinopathy, here you have formation of these fine pre-retinal vessel neovascularization, which is visible on the optic nerve or on the retinal surface. Then macular edema or retinal hemorrhage may actually be visible on fundoscopy. So this is the picture that I wanted to show you guys. I'm never lonely because these little guys are always with me. So this is what floaters look like. I don't even know how they got this picture, because I'm sure you've seen one of these things in your visual field here or there, or maybe it's just me who has a problem and I should go get my eyes checked. But I'm sure you've seen these floaters. Only you can see them anyways. So here again is diabetic retinopathy, an image. Comment in the section below what you see, and I will respond to your comments. So what investigations can we order? We can get a fundoscopy for a diagnosis. We can get a color fundus photography, which is pretty much going to be helping in grading the level of retinopathy. A fluorescein angiography, which is used to determine the extent of the retinopathy. This is specifically to assess the leak from the fragile new vessels in the proliferative diabetic retinopathy. It can also be used to develop a treatment plan. It can be used also to monitor the results of treatment. We can do an optical coherence tomography, which is used to assess the severity of macular edema, as well as to treat, or rather to monitor the treatment response. We should screen patients, and early detection is very important. All diabetic patients should actually have an annual dilated ophthalmological examination. Pregnant patients with diabetes should be examined every trimester. And of course, vision symptoms such as blurred vision are actually an indication of referring to the ophthalmological clinic. So for management, the unaffected diabetics and patients with non-proliferative diabetic retinopathy, we should control the blood glucose, we should control the blood pressure to slow the progression of the retinopathy. For those that have proliferative diabetic retinopathy with vitreous hemorrhage or even extensive neovascularization, pan-retinal laser photocoagulation can be done. I'll show you a picture of what it looks like. This may also be indicated in patients with severe non-proliferative diabetic retinopathy. Vitrectomies can also be done in those patients with vitreous hemorrhage persisting more than 6 months or tractional retinal detachment. For macular edema, intraocular injections of antivascular endothelial growth factor can be given, and you may sometimes perform intraocular corticosteroid implants, focal laser photocoagulation, and or vitrectomies. For those that are high-risk patients or complicated proliferative retinopathy, we can give the antivascular endothelial growth factor drugs. We can also perform pan-retinal laser photocoagulations and sometimes vitrectomy. Remember that clinically significant diabetic macular edema is going to be treated with the same injection of these antivascular endothelial growth factor drugs and with focal laser photocoagulation. So the intraocular dexamethasone implant and the intravitreal triamcinolone can actually treat eyes with persistent macular edema. In actually certain other countries, an intraocular fluocinolone implant is actually available for patients with chronic diabetic macular edema, and vitrectomy can actually help in recalcitrant diabetic macular edema. But of course, the ophthalmologist is going to be deciding all of these. In a selected number of cases with severe non-proliferative retinopathy, pan-retinal laser photocoagulation may be used. However, usually the pan-retinal laser photocoagulation may be delayed until the proliferative retinopathy actually develops. Then with the proliferative diabetic retinopathy with high risk characteristics of vitreous hemorrhage, extensive pre-retinal neovascularization, or even anterior segment neovascularization or neovascular glaucoma, we should treat this with pan-retinal laser photocoagulation. So this is like a very major thing and usually the primary treatment. So studies actually have shown that there is some support of using intravitreal antivascular endothelial growth or endothelium growth factor drugs in the treatment of proliferative diabetic retinopathy. So these treatments actually significantly reduce the risk of severe vision loss. So remember that with pan-retinal photocoagulation, this is the primary treatment of proliferative diabetic retinopathy. So the rationale behind this is to reduce the production of the vascular endothelium growth factor by reducing the oxygen demand of the peripheral retina. So clinically, it's seen as a cluster of these burn marks on the retina, which have been created by a laser used in the process of treatment. So this is what it looks like. So this is after a pan-retinal photocoagulation. And then with a vitrectomy, this can actually preserve and often restore the lost vision in patients with persistent vitreous hemorrhage, extensive pre-retinal membrane formation, tractional retinal detachment, and recalcitrant diabetic macular edema. Now we'll move on a step further and look at hypertensive retinopathy. Remember that this is pretty much vascular damage that's going to be caused by hypertension. The signs usually develop late in the disease. And remember that hypertension is a major risk factor not only for retinal disorders, but for renal as well as the diabetic retinopathy. You may have retinal arteries or vein occlusion, and it also puts them at risk together with diabetes at greatly increasing the risk of visual loss. And remember that patients with hypertensive retinopathy are at high risk of hypertensive damage even to other end organs such as the kidneys. Now, when you have an acute blood pressure elevation, so typically this is going to be causing a reversible vasoconstriction of the retinal blood vessels. And in patients that actually have hypertensive crisis, they may actually even have optic disc edema. So with prolonged and more severe hypertension over a long period of time, there may be some exudative vascular changes. This is as a result of endothelial damage and necrosis. Then other changes may include things like arterial wall thickening, atriovenous nicking. Typically, these are going to be over years of elevated blood pressure. Smoking actually worsens the effects of hypertensive retinopathy. So what are the clinical features? So the symptoms usually don't develop until late in the disease, and they're going to be including blurred vision or even visual field defects. So in the early stages, the fundoscopy actually is just simply to identify the arteriolar constriction with a decrease in the ratio of the width of the retinal arterioles to the retinal venules. Then with the chronic or poorly controlled hypertension, it's going to be causing permanent arterial narrowing, atriovenous crossing abnormalities, which is your atriovenous nicking. I will show you pictures of what this is. Then the arteriosclerosis with moderate vascular wall changes, which is your copper wiring, to more severe vascular hyperplasia and even thickening, which is what we refer to as the silver wiring. So you first have the copper wiring, then the silver wiring. There'll be an increase in the reflectiveness of the blood vessels. Then sometimes total vascular occlusion can occur. Atriovenous nicking is actually a major predisposing factor to the development of a branching retinal vein occlusion. If it's acute disease and it's severe, then you may have superficial flame hemorrhages, small white superficial foci of retinal ischemia, which are your cotton wool spots, your yellow hard exudates, and even your optic nerve or your optic disc edema. I've already explained what the yellow exudates are. It's pretty much intraretinal lipid deposition from the leaking retinal vessels, and the exudates can actually develop a star shape within the macula, and particularly when hypertension is severe. So in severe hypertension, the optic disc actually can become congested and edematous. So we call this as papilloedema. This is a feature of hypertensive crisis. How do we grade? So grade 1, you just generally have generalized arteriolar narrowing. So the arterioles actually become narrow. There's silver wiring, which is increased reflectiveness. So you may have thickening of the arterioles, copper wiring that eventually leads to silver wiring, and the vessels become very twisted. They become tortuous. Then in grade 2, you have everything that you had in grade 1 plus atriovenous nipping, which is produced by thickened retinal arteries as they pass over the retinal veins. Then in grade 3 is everything that you had in grade 2 plus your cotton wool spots, you may additionally have your flame-shaped hemorrhages and your soft exudates. Your cotton wool spots are your soft exudates. These are due to small infarcts. Then with your grade 4 is everything that you had in grade 3 with papilloedema. You may have blurring of the optic disc margins. So this is what atriovenous nipping looks like as the vessels are crossing over each other, like here. You can see what's happening at this point here. And with papilloedema, it's actually going to be the swelling of the optic disc secondary to raised intracranial pressure in some of the cases. And it's actually a general term referred to any cause of the swollen optic disc. So it's not just with hypertension. You may have other causes like an intracranial space-occupying lesion, optic neuritis, which is seen in multiple sclerosis. You may have malignant hypertension, uveitis, which is caused by TB and even sarcoidosis. And remember that the optic disc margins may appear blurred and small hemorrhages may actually be noted. This is what it actually looks like. As you can see, there's a hemorrhage over there, blurring of the optic disc margin. You may even have obscuring of the vessels over there. So this is optic disc edema or papilloedema. Now, what about malignant hypertension? This is what we see if someone has a grade 4 hypertensive eye disease, which is going to be including all the features from grade 3 plus optic disc swelling, your papilloedema. So other features include headaches, eye pain, reduced visual acuity, focal neurologic deficits, and then the initial management is typically giving them antihypertensive and emergency hospital admission. So there is an image that actually is going to be showing extensive hemorrhage, cotton wool spots, optic disc swelling, and a ring of exudates around the macula, which is known as a macular star, which is, of course, what is being shown in this particular image. Is a very, very nice picture to actually show and bring on an OSCE station. So here are the cotton wool spots on this schematic diagram here. I don't know why I like the word schematic on the illustrated diagram here. So here are your cotton wool spots. Here is swelling of the optic disc. You have your extensive hemorrhages over there, and you have your exudates surrounding the macula, which is known as your star, your macular star. Okay, so these are your changes that you see in hypertensive patients. What's the diagnosis? We're going to make a diagnosis by the history, the duration, and the severity of hypertension. We'll also perform a fundoscopy to look for those changes that we just highlighted. And how do we manage? So hypertensive retinopathy is managed primarily by controlling the hypertension. Other things that may threaten the vision should be treated aggressively. If the patient has diabetes, please make sure that you treat that. If vision loss actually occurs, we treat this with, of course, if it's retinal edema, you treat this with laser or even intravitreal injection of corticosteroids or antivascular endothelial growth factor drugs, which are already alluded to earlier on. They may sometimes help. I really hope you learned a lot about diabetic and hypertensive retinopathy, and the next time someone asks you to explain, you have a better understanding. If you did, consider subscribing to the channel, hit the bell notification icon, drop a comment to show some support, and don't forget to drop a like. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.